Hello, everyone, and thank you for joining us for the first installment in the financial webinar series in collaboration with Eric Schell from Stroudwater. We'll get into his intro in a little bit here. My name is Caleb Blazinski, and I'm the Telehealth and Outreach Coordinator here at the DRCHSD program. We want this course to be interactive and informative, so if you have a question, please feel free to either unmute yourself or find the chat box there in the Zoom controls. We do ask that if you are not actively speaking, to keep yourself on mute so that we don't interrupt the speaker and that we cut down on any feedback. And this session is being recorded and will be posted to the website prior to the completion of this session. As always, the DRCHSD program is funded by the Delta Regional Authority in collaboration with the Federal Office of Rural Health Policy. The center is committed to diversity, equity, inclusion, and anti-racism, and building a culture where difference is valued. Learn more about what we do with DEI on our website, or send me an email. I'd love to have that conversation with you. I will turn it over to Nick McRae, one of our program specialists, to introduce our speaker. And as he's doing that, I will be pulling up the polling questions.
Thank you very much, Caleb. Thank you all for being with us today. This is certainly an exciting opportunity we have to work with one of the most influential people in the rural healthcare space. Mr. Eric Schell, our guest speaker today, has had over 30 years experience in financial and operational management and consulting, and performed everything from rural hospital strategic planning and feasibility analysis to improving finance and operations in rural health clinics. And he's truly a influencer in the rural health space that has had a tremendous impact his entire career on where we are today and the resources we have. So very excited to have him leading this with us today. And without further ado, I will pass it to Mr. Eric Schell for post-pandemic priorities.
Thanks, Nick, and appreciate those very kind words. And good morning to some of you. Good afternoon, like me, to the others. And really look forward to having this conversation. It's it's almost the weekend, so and it's a long weekend at that, and one of my favorites. So this presentation is really about we've just spent 24 months in the trenches battling the COVID, and want to talk about kind of what's going in the marketplace while our heads were down in the trenches. And then how do we want to think about that? Yes, for those of you who know me as the shaky bridge guy, yes, there's going to be a reference to the shaky bridge, because the market forces that have been going on are going to force us even faster to start looking at some of how do we cross that bridge. And so we'll talk a little bit about that, and then come up with some list of other imperatives that we really have to think about and why. So with that, let me kick this off. We got 33 slides. I have no idea how we're going to get through it, but we're going to give it a whirl. As we just presented, the market hasn't stopped moving, and there's a number of things that I want to highlight related to that, and and some of them include the cost of healthcare and its continued rise, the advances in technology and how they may have an impact on our future strategies, and some of the outcomes of those, including inpatient and outpatient volume declines, and then a transitioning payment system led to some degree partially by the government and partially by market forces. And so all of this has been going on while we have been head down, fighting day to day to take care of patients and dealing with some of the ramifications from COVID. So I want to just touch on a few slides around, kind of what this means and how I think it plays out. The first is, as we just presented, was this insurance premium and the continued rise in insurance to, back in 1999, where a family of four had a premium of $6,000. And now that number is $22,000 as of 2021. The couple relevant pieces of this, there's three. One is that at 22,000, the healthcare premium is a third of household income, and which is really taking its toll. The second is that there's a step increase in costs that to some degree see no end in sight. And the third piece of this is that when we, general economic theory says that as price goes up, there's two things that happen. First, in general, demand goes down. So demand for healthcare services, or in this case, insurance, goes down, and supply increases to bring price back down. And so, what they say is the cure for rising prices is rising prices. So let's just take a look at those two sides of the equation. So in terms of the reduction in demand, to some degree, the government has stepped in and through subsidies and the exchanges and has really said, okay, we are going to subsidize those that in outside of, if there were no subsidies, would not be able to afford insurance anymore. The government stepped in. So to some degree, the demand equation has remained constant, even though in a pure market, that demand would go down. On the other side of that coin, the supply and demand coin, is supply. And again, as price goes up, more supply comes in. And the next couple of slides are really around what that supply looks like. And we're going to keep going back to that because it just so happens that technology, at the same time, the cost of healthcare has gone up and up and up, introducing the concept of more supply has essentially enabled, through this revolution in technology-based companies that don't think that healthcare is as much data-driven as they are, think that there's a business opportunity. And I've got a few slides. I mean, I just find these amazing, and I like to share them with you because it's amazing. This has all been going on during the pandemic, but you've got Amazon, and Amazon's the one that scares me. I can't imagine another 12 months goes by and Amazon doesn't come out with its own insurance as a product offering. Now, don't hold me to that, but I just see what they're doing and say, wow, why wouldn't they? But, so they did a couple things. One, they announced this Amazon Care, and they have telehealth services now available nationwide to organizations that, to companies that sign up, in which they guarantee 60-second response time to a patient calling in. They've also introduced, and it's going to be in 2022, they plan on rolling this out to 20 major cities, is this in-person care where you put a call in, within 60 minutes, you'll have a provider show up at your door with a toolkit toolkit full of diagnostic equipment to help assess the condition. And so, this is going to be in 20 cities. Now, most of us in rural, we're not going to see this in our cities, but the telehealth piece is actually pretty big. Then Amazon introduced Amazon Pharmacy. This came out in December of 2021, where consumers can shop for best prices. They're pharmacists that work with the prescriber and the insurance company, and frankly, with Prime, and many of us have Prime, we can get the medications delivered. You can just take a look at some of the examples here around the different. They list they have retail price, the $174 for this List Pro versus the Amazon price of $50. You can see some of the other examples here. My fear for this within our rural hospitals is so many of us have our bottom line is the 340B net. I hate to say profit, but the all right, I'm going to say it, net profit associated with our contracted retail pharmacy, and what impact will Amazon Pharmacy have on that piece? Then you got Walmart. They don't want to be outdone by Amazon. And Walmart, I don't know if we've noticed, but in the last several years under new leadership, they've taken a very proactive and abundance type of viewpoint on the world and gotten big time into healthcare, where they've added virtual care, discount drug programs, a unified electronic health record, and they've opened up freestanding health centers. Direct-to-consumer telehealth, doctors on demand, all of these services are around providing, a greater level of access to primary care. And so, Walmart's a big player. Walgreens is saying, there's the CEO of Walgreens has a comment. I'll circle it out. I put my marker on it right now. And this is their vision. Imagine a day when 45% of our Walgreens stores, you can walk in and see a primary care physician that's attached to our Walgreens drugstore. Again, so many of us in rural America, we are a primary care based delivery system. And now we've got folks like Walgreens stepping in and making a concerted effort around our core business of primary care and access to CVS, right? CVS is now, Aetna and CVS came together, and CVS is making a big splash where they've by the end of 2021, they had opened 1,500 health hubs, up from 650 2020. Again, this is all in the midst of the pandemic, and as we were fighting the fight. So they're growing health hubs. They just announced the investment. I think about a significant investment in housing in areas where they're trying to look at the social determinants of health. So CVS has really jumped into this, the E platform as well. We've got United Healthcare. They bought Optum Care, a year and a half ago, with 56,000 physicians and 1,600 clinics. And United Healthcare now is the largest employer of physicians in the United States. And they're looking to have $100 billion book of business in healthcare, also launching virtual care and all these. Anthem just came out. Many of us have Anthem. I know it's a big insurer here in the state of Maine where I live, where it's 78 degrees this morning. And they announced back in February, a couple of months ago, this expansion of a telehealth primary care service in 11 new states. And they eventually want to offer it to 10 million self-insured lives by the end of 2022. The other piece that scares me about Anthem is this new program that they're launching called Virtual First, in which the plan requires members, their members, to see one of their Anthem providers via telehealth before they can even come visit our own primary care or specialty care. Right now, that's available in 6 states, and they're looking to expand that depending on regulatory approval. So, gosh, I mean, think about what the impact that's going to have. They're looking to get at the front end of keeping people out of our hospitals. And then I show this because, oh my gosh, if we think about, especially in Q3, Q4 of 2021 and Q1 of 2022, if you can kind of just read through some of the headlines here. Carbon Health banks another $350 million from private equity firm, become, quote, the largest primary care provider in the US. One Medical acquires, let me see which ones Iora Health, a leading value-based primary care group serving Medicare patients at 47 offices. Here's another one. Humana gets $600 million from private equity firm to invest in expanding primary care services. Right below that, a private equity firm invests $500 million in Florida-based primary care group. Look at the Wall Street dollars through private equity. They're being invested in primary care. And what's really happening is the value of primary care. The formula, let me just share it. The formula is eventually payment as we move to a population-based payment system. The dollars, average per capita healthcare costs in the United States, $10,000. One busy primary care with practice with 2,000 patient lives attributed to it through attribution is going to be worth $20 million. Wall Street has figured it out. And I encourage you to start thinking about your primary care providers as something that Wall Street thinks that there's a big money play on, and in making these types of investments. Again, going back to, and I keep going back to this, all while pandemic is going on. This has all happened. And so the result of some of this, right, is more and more people get into the front end and take business away from us in the hospital space. This is just an example of 5 states in the Mid-South area that we've seen, continued decline in inpatient volume. Now, we live in a world, our fee-for-service, our fee-for-sick care payment system is one in which price times volume is net revenue. And for inpatient services, we're seeing this continued decline in inpatient services, which for our rural hospitals, it's 30% of our business. But again, price times volume is net revenue. When volume's going down, things are going to start to struggle for us here. Now, obviously, the pandemic funds propped up some of our financial performance over the last 2 years, but they're not. I just had a call this morning with a hospital in Missouri that they're likely going to be returning some of theirs, and they're starting to struggle here. So, and then the last one was this decline in hospital outpatient volume. This was reported a year and a half ago by the American Hospital Association, the first time in 35 years that hospital outpatient volume actually declined. The interesting comment about this study was that it's this, I'm highlighting it right here. It's the third bullet down, is that the report cites that the amount of outpatient care delivered has most likely increased, right? As an aging population and, some of the, disease that the kind of obesity and high blood pressure and all of these things, outpatient volume has actually increased, but that care is being delivered in competitive new options, such as urgent care, retail clinics, and et cetera. This was as of 2018. And everything that we just talked about in the last 12 slides was since 2018. So it'll be interesting to see what's happened now once we smooth out the variation of the last 2 years caused by COVID, and to see if this is continued decline. Again, price times volume is net revenue. Inpatient volume we just showed going down. Outpatient volume, if that's starting to go on, if we want to maintain revenue, either we got to figure out how to capture more market share, or we got to figure out how to increase the other side of the equation, which is the price side, how much we get paid. So some of the result has been over the last several years, we've seen a decline. This is Medicare margin by hospital type. The gray bar is all hospitals. And this comes out, this is MedPAC's report to Congress. And I did include provider relief funds, especially in 2020. You can see some of the impact, especially for the blue line is rural, excluding critical access hospitals. The orange is rural, including critical access hospitals. So we did see this uptick with the provider relief funds included. But anyway, I just want to, beginning with when the Affordable Care Act was passed in 2010, there was a piece of it that was, very interesting. Obviously, we talk about the insurance and we talk about the ACOs and all of that. But one of the things that was built into the payment formula, right, the price side of the price times volume is net revenue calculation, was that the government was going to pay an update to fee schedules that was going to be tied to market basket, so inflation, less. And over the last 6 years, it was less 0.75%. Now, what happens is if you start taking market basket less 0.75%, and you start doing that year over year after year for 6 years, that has a compounding effect. And now what we have in this formula of price times volume is net revenue is price relative to cost from your major payer is actually going down. And thus this is kind of, I would say this is the direct result that we saw here between 13 and 18. We started seeing an uptick here in 18 and 19 as a result of 340B and some upcoding and things like that hospitals had to do. So, then we have the director of Centers for Medicare and Medicaid Innovation, right, CMMI. A year ago, she came out with a statement. And I want to talk about how that statement is now playing out in terms of actual regulation. She made a couple of comments and we've circled them. She said, fee for service. We can't have fee for service remain a comfortable place to stay is point number one. The second is that we have to be, essentially what she's saying is one size does not fit all when it comes to ACOs, accountable care organizations, and alternative payment models. And so, if you think about how do we make fee for service a difficult place to be, And then the lever the government has is around that price, right? That price side of that price times volume equation. And so if we're going to make fee for service uncomfortable, we're going to continue to put downward pressure on price so that that formula starts to collapse. And then we'll talk. And so how did that play out? Well, MedPAC met back in January, and their commissioners came out and they said, boy, we should pay hospitals an update factor of 2%. This actually, the regulations or the proposed inpatient rules came out in middle April and actually said the update factor for 2023 is proposed to be 3.2%. Now, if you think about 3.2%, I'm not sure I've run into any rural hospital as I travel around the last 3 months that has their cost going up less than 6 or 7 or 8%. So if payment update is scheduled at 3.2% increase, but our costs are going up 8%, cost or price relative to cost is going down in a big way, thus making fee for service a very uncomfortable place to stay. The second is back in January, MedPAC actually, their commissioners met and they recommended that, back to Dr. Liz Fowler's second comment about, one size cannot fit all for ACOs. And so MedPAC actually came out with the this three-track approach, moving away from the prior administration's pathways to success, in which the MedPAC commissioners came out, and frankly, this just came out 2 weeks ago in their June 15th, 2022 report to Congress. For chapter 1 of this, 600-page report was all around how ACOs should be structured based on the ability of the hospitals to take on risk. And there's 3 types of models that they're talking about. One is that there's a small hospital, small provider, where they don't have to take on any risk. And that makes sense if you think about it. If you're only getting 30% or 35% of the total dollar, where the other 65% is going on to the big city, there is no possible way we could take on full risk for the 100% of the premium or the dollar. And so, model number 1 is no risk. Model number 2 is less risk, but up to 75% of shared savings. This is for your mid-sized organizations. And then finally, for your larger health systems, full risk and 100% of shared savings. Sounds like a Medicare Advantage plan to me, but that's MedPAC, put this out. They recommended in January, built it into the report in June, recommending to Congress that we rethink ACO to better work for rural America. Again, back to Liz Fowler's comments, we're going to make fee for service a difficult place to be. We just talked about that. And we're going to tweak the ACOs so that kind of everyone can participate to the extent of their ability to take on risk. So, really a summary of all of this is, the pandemic's been going on. Our heads have been down. We've been fighting staffing problems and morale and sick patients. And at the same time, we've got a payment system that's continuing to transition to value. There's going to be increased pressure for operation efficiencies as the cost of human labor keeps going up and payment goes down. We've got to figure out how to become more efficient. Increasingly, clinical integration to start to look at these new alternative payment models is going to become an organizational priority, but flexibility has to be ingrained into any type of strategy to address the timing of when this is all going to fully roll out. So, I want to talk about why I think that rural hospitals in the new world, in the payment system world, of alternative payment models, ACOs, have incredible value. And it came out of the regs that I read years ago, in which it said a primary care physician can belong to one accountable care organization. Hospitals and specialists can belong to multiple ACOs. And when I read that, how it struck me that, boy, rural has a real opportunity. And the opportunity is because we are a primary care-based delivery system. What that statement just said is that in the future, the revenue centers, in other words, the primary care physicians through patient attribution are going to be revenue. They're going to be the revenue denominations. The bricks and mortar technology specialists are going to become cost centers overnight. Because rural hospitals are uniquely positioned as a primary care delivery system, they're going to have upside value in this new world. And to the extent that we have our strength and our alignment with primary care physicians, that we don't let Wall Street come in and private equity come in and pick off our primary care as they see the value, and often we don't in rural at this point, that the strength of our future is in the strength of our relationship with our primary care base. That we are highly efficient and that we focus on high quality and pursuing quality goals. All of this is keys to success as we start to think about this world that is accelerated through the last 24 months. I like to present this slide. Many of you probably have heard me talk about this, but I think this sets the stage for how we are going to see the system of the future. If we believe in the premise that form follows function follows payment, right? How we organize ourselves, the form, is to meet the functional imperatives of a payment system. For example, the functional imperatives of a fee-for-service, fee-for-sick care payment system. If one organization manages one's own price, how much we get paid per unit of service, the units of service, number 2, and number 3, our costs. One organization operating in isolation can be successful in this episodic sick care payment system environment. And so the form over the last 50 years is independent organizations competing with other independent organizations for market share. If we think about the new payment system where we're getting paid to care for a population, and the functional imperatives change fundamentally, we still have to be able to offer sick care, but now we have to start thinking about how we're going to provide true healthcare in our communities. And that's going to take relationships. We've got to, first of all, aggregate enough population to diversify insurance risk, but then also be able to provide both healthcare and sick care services, whether it's public health, diet, engaging people around diet, post-acute care, ambulance, specialty care, tertiary care. All of this is going to be a part of caring for both the health and sick of a defined population. And if you think about those are the new functional imperatives, the form that will really have to, there's 3.5 trillion reasons why this economic force is going to really have organizations coming together. And you already see it coming together in places where population health is front and center. For example, Western Pennsylvania, where you've got UPMC with 7 million covered lives, a 30 hospital system in Western Central Pennsylvania, where they're just accumulating hospitals to aggregate scale. You've got, your Kaisers of the world, kind of Intermountain Healthcare, Presbyterian Healthcare in New Mexico. All of these are organizations in which they've come together for the exact functional imperatives of this new payment system. And so I see this as the form of the future.
Eric, we have a question in the chat here, sir.
What do we got there?
Regarding the MedPAC and the three-track model, does that essentially mean the global budget models have taken more of a backseat? Is that what we're saying?
No. I think that the global budget models are still in the exploratory phase. You've got Pennsylvania in looking at, they've developed the Pennsylvania global budget model. You've got Vermont now becoming more interested in it. But you got not the REACH? Yeah, the REACH. Is it the REACH? I'm sorry, I'm blanking. But they're experimental right now. They're, do these types of programs work? And so, I'm having conversations with a health system in Vermont right now, and they're one state ACO. All payers are participating in this one state ACO, and essentially communities can come in and decide what their payment system looks like and how they get paid as individual entities. And what's increasingly the conversation is, I'm working with this one community where the primary care group, they still think it's appropriate to be paid on a fee for service basis to encourage higher utilization of the tens and hundred denominations, where the hospital is considering thinking about a global budget to kind of lock down so that they can get invested in. So invested in actually, sick care and true healthcare. So I see global budgets as the next phase, as the next phase of payment to the individual entities participating in an ACO.
That sounds great. Thank you very much.
Yeah. And thanks for the question. Answering questions is a blast, although we got time here. And so, we keep talking about payment, right? We talk about payment as driving the functional imperatives and this is something that CMMI came up with several years ago, their former deputy director, where he looked at payment as an evolution, not a revolution. This isn't something going to happen overnight. To some degree, the market is likely to force it. And the market, combined with CMS's ability to affect that equation of price times volume is net revenue, right? You see the market conspiring to take out the volume side, and then CMS has the ability to affect the price side. And so what you got is you got an evolution of payment where the orange, this is just straight fee for service. Let's put this on 2014, because I don't believe this exists anymore. Most payment systems have evolved. Most of us today are living in this category 2 of payment where it's still heavily fee for service, but now we've got some incentives around quality and utilization control. And again, I'd say 95% or 90% of the United States is in this. Category 3, you have alternative payment models built on a fee for service architecture. And this to me is kind of danger land, because everything that we do here to create value towards the alternative payment model shows up poorly on our income statement, and our CFO and CEO get fired and everybody's frowning. And then as we start to move, the last evolution is population-based payment built on a population-based infrastructure. Think of this as Kaiser. I think they're probably one of they're the only one in the country that I believe that truly believes that when their hospitals are empty, they are successful. And this is, and where their revenue is premium dollar through the Kaiser Health Plan. And then what they choose to do with those premium dollars is in appropriate investments in healthcare and sick care to maximize that residual claim on health. In other words, if we can reduce the cost of delivery on a combined basis by 10%, that's that residual claim on creating health, and it ends up being profit to a Kaiser. And if you could just see their profits over the last several quarters, it's pretty outstanding. Except for the last quarter, but that was primarily non-operating. They lost a lot of money on their investment incomes. So we got to cross the shaky bridge, and there it is. For those of you who are snickering right now, and oh my gosh, here's Eric going again. This one graphic though it's a picture that shows it's 1,000 words. Here you are over here, fee for service, payment system 2014, blue bar on the left, right? Until this blue bar, this is the bar of price times volume is net revenue. This is a great bar until things like costs are going up 8% and fees, what our third-party payers and Medicare are only giving us 3% increase to the price. And then volume starts going down through new competition from technology-based companies and others. All of a sudden, this is moldering. Over here, but it was steady as long as it existed, right? Because the more sick care you do, perfectly aligned payment delivery system, the more sick care you do, the better off you do financially. You have a pillar over on the right, the green, where the less sick care, the more health care you do, the better you are. Ask Kaiser. And this is, this very stable platform. Again, payment system, delivery system, completely aligned. Everything in the middle is schizophrenia. And we're in that right now. We're here. Now, the beautiful thing is if you go back to that payment system evolution identified by CMMI, where I look at that second phase of payment. We'll go back one slide. This right here, fee for service with links to quality. It's where we all are right here. It's okay. We've stepped off of this fee for service, but our feet are above the crocodile still. And we can still maximize fee for service and be okay until we get to the next payment where the feet are right above the crocodiles. And there's one almost, biting his shoe right there. And this is because everything that we do to create health in our population shows up poorly on our financial statements and gets CEOs and CFOs fired. And then as we start to evolve to the next, form of payment, this one over here, population-based payment on a population-based infrastructure, is we start to emerge away from the crocodiles. So what's tough is that it's going to get worse before it gets better, and which is making this very challenging because people get here. A year ago, I gave a presentation to Vermont. I consider them one of the leading states around evolution to population and alternative payment models. But I found them being stuck because people didn't want to go here for the risks that we just talked about. So everyone's stuck here, and the hospitals are starting to lose money, and they didn't know what to do about it. And so, but again, we've got to figure out how to take this next step, even knowing it's going to get worse before we can get across this. We can't just step from here to here. And the reason is because we don't have a health system. We have a sick care system. It's going to take time to develop it. The other piece of this is insurance companies. They really don't want to give up, their gravy train that they've lived on. And finally, the hospitals that just don't, it's tough because it's going to get worse. And so we're kind of stuck right here. And so what Stroudwater did is several years ago, and I know many of you have seen this, is we've created this graphic to help rural hospitals think through how to get from, here's 2014, right? This is payment. I'm going to go across the x-axis. This is time. Let's put 2034 here, way out on the right. Most of us is in this phase one of payment, right? Because payment dictates functional imperatives and form. So let payment be the change agent over time. Phase two of payment, this is those, feet right above the shaky bridge, alternative payment models built on a fee for service infrastructure. And then this phase three is where we start to evolve out the other, we get to lift our feet away from the crocodiles. So over time, so there are three health systems, rural hospitals have to think about three strategic areas to address simultaneously. The first three initiatives are around transforming sick care, the current delivery system. We have to transform it. We have to create a health system. We don't have a health system, but if we don't want to create a health system too quickly, because if we do, it reduces our fee for service volume and we're in trouble. So think about creating health system from the perspective of crawl, walk, run, sprint as the payment system evolves. And then we have to proactively pick up and move payment. And in the end, when sick care, healthcare, and payment come under one umbrella, what we believe is, the economic result of where the delivery system's going now are the large health systems, the Kaisers, the Intermountain Healthcares, the UPMCs of the world, in which sick care, healthcare, payment come under one umbrella. But what we did is we identified three initiatives to transform sick care, three initiatives to transform healthcare, and three initiatives to transform payment. And I just want to, and one more complicating factor, apologize for this, is the orange bar coming down is the strike point. When the initiative here hits the strike point, we have to do it. So the first initiative here in transforming sick care is we've got to figure out a way to become more efficient. We have to have quality as a competitive driver, and we have to engage patients. And we got to do that today. We've lost 138 hospitals that haven't figured this out, that the payment system has evolved, and we've got to do this. The second was we've got to align with our primary care. So today, everything going on today, we've got to figure out how to plan for, by the time the payment system gets to here, we fundamentally align with primary care. Because again, think of them as a busy practice worth $20 million in the population-based payment world of the future. The third is service area rationalization, coming together with larger systems to take out big chunks of fixed costs. And the big chunks of fixed costs, when the payment system gets out to here, the strike point for this is technology, bricks and mortar, and specialists. Most of that is not in rural America, and most of that is in the big cities. So today we got to start a strategy, implementation plan in the future, and then a strike point way out. That's how we transform sick care. Create healthcare. Let me just focus on the first one because that's really what's important. Let's create the infrastructure only. Patient-centered medical homes, team-based care, use of data analytics to drive decision-making, evidence-based protocols. All of this is things we can do now that maximizes fee-for-service, but creates a position on the future. And we go down here today. We have our own self-funded health plan. Have we designed our own employee health plan at our hospital? So to encourage patients or our employees and their dependents to use our hospital. Do we have disincentives for unhealthy behavior? Do we have incentives for healthy behavior? Have we enrolled our chronic patients in our own patient-centered medical homes, in chronic care management programs? These are all things that we can do, and then maximize any opportunity to get paid for healthcare, i.e. annual wellness visits, chronic care management, behavioral health management. All of these, we get paid for providing healthcare. As we move up, we got to start today thinking about the ACO transformation so that we can strike in the future, and then the full risk plans. But essentially what we think is that strategic planning for rural hospitals has gotten much more complicated. It used to be just here, the first row and second row. Now strategic planning really has to incorporate all 7 of these rows if we're going to be able to maximize fee for service, but create a position on the next payment system. And so the next couple of slides just walk through this, and then we're going to wrap up. So operate, so the initiative 1, we're first row. The best way for a rural hospital to be highly efficient is to increase patient volume by locking down market share, reducing out migration, because we're 80 to 85% fixed or step fixed costs. Anything that we do to increase volume, paying volume, dilutes our fixed costs over more units of service. Our revenue cycle practices, if we're not at 45 days in AR, aggressive around denial management, measurement culture, all these things, we're in trouble. Expenses managed aggressively. I don't want to hear just because we're a critical access hospital, we shouldn't be managing our expenses aggressively. Cost-based reimbursement is only good for 40 or 45% of your business. The other half, you have to make money on unit costs. Effectively managing our physicians, and then effective organizational design. We have to be able to compete on quality. We should be able to compete with every hospital within a 100-mile radius of us. This is an example of a critical access hospital in Western Massachusetts. They, on an HCAP score, they are the top quality hospital in the state of Massachusetts, 5-star. And the green here means it's the best of all of the competition around them. The light green means you're above national averages, but not the best. Pale orange means you're below national average, but not the worst. And dark orange means you're the worst. This hospital, at the time we did this study, they were the top of all of the competition. And let me just say that they're operating out of a 1928 inpatient unit. 1928. They're an old TB hospital that sits on top of a hill. They consider quality, patient safety, and engagement a top strategic priority, and they've delivered on it. Primary care alignment. We just talked about the fact, if nothing else you take away from this presentation, understand the value of primary care. Think about that, kind of look at your primary care base. Just because they're employed does not mean they're aligned. And just because they're independent does not mean they aren't aligned. The key is to standardize alignment. Alignment is going to be the key. And we look at that as this interdependent relationship built on contractual alignment, functional alignment, and governance alignment. And we've got to really think about that so that we can strike point when the payment system evolves. Service area rationalization, we'll jump over that. That's just, kind of seek these interdependent relationships with emerging systems where you don't have to give away the soul of your hospital. You can maintain independence, but seek the benefits of this interdependent relationship. And then the payment system, right? So we moved all the way down now in that transition framework to the last row. and self-funded health plan, you're already at risk, either directly or 1 year removed. Change benefits to consumerism, enroll employees in health programs, and then all of these opportunities to get paid for health-related activities now, maximize the heck out of them. I'm going to jump through this one because this is really that second column. And then start to build your population health. Don't go too fast, but patient-centered medical home. I highly encourage, if you haven't heard the term team-based care, do some research on that. I believe that is the future of how we have to organize our primary care practices, and leveraging up the patient-centered medical home features with team-based care. Care management programs, make sure that those are evidence-based protocols. You start to develop claims analysis capabilities. If you're participating in an ACO, are you using those claims to drive performance? Looking at where patients are going and could we have provided those services? A great opportunity for us. And so, I look at the, I guess the whole slide comes, this whole presentation comes down to this last slide right here. So if I put you to sleep for the first 31 slides, wake up. Here is what I believe that we have to do immediately, and implement over the next 6 months. If we're going to cross this shaky bridge, I think we really have to start thinking about that today. A strategic plan should definitely consider as a base input a payment system that's evolving. Now, strategic planning for the last 50 years within healthcare, it assumed a static payment system. But as a payment system is flipping and our functional imperatives are changing fundamentally, we've got to start building that into strategy. And so, kind of this, to do this, we've got to be proactive and we've got to plan for it. So market forces that are at play here that are going to require these new strategies. Doing next year a little better is not going to work anymore, or we're just going to kind of wake up to a payment system that no longer exists, and we're going to be perfectly, what's that old saying? We'll be perfectly designed for a world that no longer exists. We just have to be really careful about that. And then again, a foundational premise of your strategic plan should be this base input is a transitioning payment system. Some of these things that we've got to start talking about is continued operation efficiencies, especially in the world of 6 to 8% increases in our labor costs in this last year. Medical staff alignment in your primary care base, I cannot emphasize that enough. Service area rationalization, starting to talk to regional players and what that could look like. Population health management, that blue bar in the middle. Let's start to build the infrastructure here to be successful in the future. And then, recognizing the payment systems are transitioning and embrace them, don't run from them. So these are kind of I would say these are over the next 6 to 12 months. Immediately, just like the call that I had this morning at 8 o'clock with a hospital in Missouri, we've got to start looking at our cash, over the next 6 to 12 months to determine what's real and what's not, i.e., do we have to return COVID-related funds? And are we going to go from 120 days cash on hand to 40? Let's best understand that. Meet with commercial insurers. We've got to get in front of our commercial insurers to discuss our costs of capital, our costs of labor, and how the increases in them, having Blue Cross Blue Shield give us a 2% raise next year, a 3% raise is not going to suffice. And there was actually an article in Modern Healthcare earlier this week that was addressing this exact issue. The article was titled something like, it may have been fierce, but it was talking about the fact that the battle is about to happen between the hospitals that are going to require higher amounts of reimbursement and the insurance companies that are really not going to be very happy about recognizing that. But that I encourage you on a proactive basis to have those conversations. Let's start to prepare interim cost reports. I mean, if we're on a calendar year end and our labor costs are up 6 or 8% this year, just this year because of the impact of supply and demand in the labor force and the pandemic, let's prepare an interim cost report now so that we start to get those higher rates paid to our critical access hospitals. And then, oh, by the way, let's get those rates submitted to the MA plans, the Medicare Advantage plans, and get higher rates. I can't stress this one enough. Leverage the goodwill received during the pandemic to recapture lost market share. So many of us prior to the pandemic, our communities really just drove right by our organizations, and with the pandemic and the testing capabilities and the vaccines and everything that we did to help our communities, people all of a sudden started to see us as a real resource, and let's leverage that. Let's continue that goodwill and accelerate it to the extent possible with a goal of capturing lost market share. We talked about the need to become efficient. If 70% of a rural hospital's volume drives right by the front door to the big city, if we can recapture 5 percentage points more of that, that's a 15% increase in volume. And that's going to drive efficiencies unlike we've ever seen, and so important. New consumer-oriented strategies. I was just at a hospital in North Carolina this week, and severely short on primary care to the point where no one could, a new person coming into the community could not see a primary care physician for anywhere between 3 and 6 months. They didn't have any open access in their clinics because all their primary care physicians were just busy. And so, what's happening is the community is leaving this rural community, going to the bigger cities or going to urgent care centers. They're seeking telehealth through their insurance companies. And we're missing out on an opportunity around keeping patients and serving our community. And so whatever we can do to have more consumer-oriented strategies, Saturday hours in our clinics, evening hours in our clinics, morning hours in our clinics, access, think about access, and then telehealth. All of these are consumer. Aggressive and proactive approaches to maintain and enhance staffing. This is another absolutely critical piece. I've seen hospitals. I had one hospital where essentially what they did is, so many of the young workforce, they just want a paycheck. They don't care about the benefits. And so one health system, they actually converted their benefits into a per hour rate. And if the employee didn't want access to the benefits, that we converted that into an hourly rate and added to the hours to be more competitive with some of the bigger systems. That was one approach. Another one was that another health system, I was at a board retreat back in April, and what they had done is severe, extreme flexibility around work hours. That they had a nurse that only wanted to work 2 days a week. Well, we can make that work. Let's talk. These are the kind of things that we have to get very, very aggressive and proactive around. And then continue our advocacy related to how rural is disproportionately impacted by some of these shortages and really have that effect. That was a whole lot of content for a Friday morning / afternoon of the July 4th weekend. And I know there's a bunch of chat questions, and I'll turn to Nick and Caleb to sort through them and ask questions, or feel free to come off mute and ask directly if you choose to do that.
Thank you so much, Eric. And please, now we have dedicated some time to answer any additional questions any of you have. We had a couple of them come through here in the chat. This was excellent, Eric. Thank you so much. A lot of great information, and certainly many different priorities that we can all be focusing on right now. With that being said, I'm really curious to see our audience that's with us today. What are some of the key priorities that Eric discussed here as immediate next steps that you all are already implementing and already seeing as generating really high return on that effort? I know many of you are working through and have been working through the financial and operational and quality improvement and all the other components of the Delta program and addressing these things. So Has anyone out there got a great example of what's been really high value to focus on first in terms of triage of these things? And feel free to come off mute if you have a really good case study to share with us here. I know we're all, given our resource constraints, we're all really interested to see what's a highest return right now on those efforts.
We wait for those responses to come in too. I will also go ahead and launch the post-polling results. Just helps us gauge the knowledge gain measured on today's webinar. So if you want to go ahead and fill that out at your convenience, and we'll wait for some potential stories or situations or questions to come on in.
Excellent. Thank you very much, Caleb.
Come on, you guys can't be shy now. You just had me do all the talking, you know, and you'd like to hear some from you guys.
That's right.
I know we takers. It's Friday.
I know we've got some traction being made in these currently. That's what I'm really interested to see. What are some of these really high value kind of things we're already seeing. And while we're waiting on anyone that would like to chime in with that, so Eric, in regards to your perspective on this, what would you say is if you were to triage efforts for these immediate priorities, what would you say would be like the top three that you'd recommend our systems to go after first? I know it's kind of tough. I mean,
you know, the consumer oriented strategies, we've got to make that a priority. I mean, in not having access to our primary care is you know, kind of, first of all, we're losing out on that revenue. We're losing out on the ancillary referrals. We're losing out on the 340B benefit. But really, we're losing out on the ability to capture a patient that may go 30 miles up the road to the big city and enter a primary care practice there that we'll never see again. And so having those new consumer-oriented strategies is going to be critically important. I think, you know, kind of sitting down with your commercial payers and really having a conversation that, you know, the good news for Medicare, for many of us that are at the critical access hospitals, you're going to get cost-based reimbursement. But that's only for, say, 45% of your business. And, you know, so, and it's not like your states are going to give you an 8% increase with your Medicaid program. So it's got to come from your commercials. Starting those conversations sooner rather than later is going to be absolutely critical. Has anybody had any of those conversations yet? And I'd be interested in to hear how it's gone.
While we're waiting on the payers, that Franklin has indicated they've been really successful at aligning their primary care through the specialties, specifically in the clinics that they've been able to build capacity on. So that is definitely for those that are have many RHCs, and really capitalizing on that was one of the main takeaways I got from this conversation.
Yeah, definitely understanding that value of primary care and the market forces that are coming around your primary care. And again, I encourage us to look at team-based care and see if we can't implement elements of that in our practices, just to preserve our physicians who are, you know, we think about our primary care physicians with the shortage that's going on now, with the demands of the medical record just crushing them, and now the demands of this population health movement. I mean, if we don't do something to prop up our primary care, we're going to burn out the entire industry. So anything we can do to help those folks, please do.
Thank you so much, Eric. We greatly appreciate your time. Thank you all for joining us today.
Bye all.
Thanks, everybody. Have a wonderful 4th of July weekend.